Adequate recovery from anesthesia has been defined as a state of consciousness of an individual when they awaken or become arousable and aware of their surroundings and identity. There is no agreed unifying definition of delayed recovery, and there is no definitive time, and the diagnosis is based on clinical evaluation. Risk factors and causes for delayed return of consciousness is divided into patient factor, drug factor, and surgical factor. Usually, delayed recovery is multifactorial, which is one or more causes combined. Patient factors are age, genetic variation, and comorbidities. Drug factor, which is the dose of the drug, which is overdose, or the patient is more sensitive to the particular dose of the drug, and the pharmacokinetic interaction like absorption, distribution, metabolism, excretion, and contact sensitivity, half-life. Pharmacodynamic interactions like summation, potentiation, and synergism. Surgical factors like requirement of muscle relaxant, prolonged duration of surgery, and positioning like sitting position, which leads to cerebral hypoperfusion, and steep Trendelenburg position, which leads to cerebral edema, and use of irrigant fluid, for example, in transurethral resection of prostate, which leads to water intoxication syndrome, cerebral edema, seizure, and coma. Other factors which contributes to delayed recovery are respiratory failure, loss of central drive, any muscular or ventilator disorders, neurological causes, any intracerebral event, seizures, central hypoxia, central ischemia, local anesthetic toxicity, and the other metabolic causes like hypoglycemia, hyperglycemia, hyponatremia, hypernatremia, hypothermia, and hypokalemia. Other causes like hypothyroid, central anticholinergic syndrome, serotonergic syndrome, and patients with hepatic renal failure and sepsis. In age factor, elderly and infants are more susceptible for delayed recovery. And genetic factors like plasma cholinesterase deficiency, myasthenia gravis, Eaton-Lamberton syndrome, and muscular dystrophies lead to delayed recovery. Comorbidities like neuromuscular pathology, respiratory pathology, which decreases minute ventilation, which leads to hypoxia and hypercarbia, which causes decrease in the clearance of inhalational agents and unconsciousness. Also in renal and hepatic impairment, decrease in the clearance of the drugs, increased in the accumulation of active metabolite of drugs like midazolam and opioids, which are 1-hydroxymidazolam and morphine 6-glucuronide, which delays to delayed recovery. And hypothyroid, which has multi-systemic effects like decrease in the spontaneous ventilation, decrease in the plasma volume, hyponatremia, impaired drug metabolism, and myxedema coma, which all lead to delayed recovery. Pharmacological causes like drugs like benzodiazepines, when given alone, which doesn't cause any respiratory depression or delayed recovery unless if it is given in an elderly people, or when it is co-administered with opioid or other anesthetic agents, it can have pronounced effect on respiratory depression. Opioid has two mechanisms. One is the direct sedation effect, and the other one is as a result of respiratory depression, it has a delayed recovery. And highly variable contact sensitivity half-life of fentanyl and alfentanyl after a prolonged infusion, which leads to delayed recovery. Then the neuromuscular blocking agents. The residual neuromuscular blockade, even in a conscious patient, mimics unconsciousness. So with the residual neuromuscular blockade, they'll hypoventilate, which leads to unconsciousness. And the drugs which interact with the neuromuscular blocking agents are volatile anesthetic agents, aminoglycosides, lithium, diuretics, calcium channel antagonist, magnesium. Other causes like hypokalemia, hypothermia, pregnancy, thyrotoxicosis, and plasma cholinesterase deficiency. They all act either by interfering with the second messenger calcium, which is involved in the release of acetylcholine, or they cause cell wall hyperpolarization, which leads to potentiation of neuromuscular blocking agent actions. And the IV anesthetic agents, The duration of unconsciousness with IV anesthetic agents are very less, but it is affected by the amount of drug, contact sensitivity, half-life, and the co-administration of other drugs along with the IV anesthetic agents. Volatile anesthetic agents, their elimination is mainly depend on the minute ventilation. So factors which leads to a decrease in minute ventilation causes increased duration of anesthesia. So we have to rule out the metabolic causes like hypoglycemia, and causes of hypoglycemia are patient with a known diabetic on insulin or oral hypoglycemic agents, prolonged starvation, alcohol intoxication, sepsis, liver failure, and other endocrine tumors. Causes of hyperglycemia are patient with ketoacidosis, hyperosmolar non-ketotic acidosis, lactic acidosis, pancreatitis. This hyperglycemia will lead to osmotic diuresis, dehydration, including cellular dehydration, which in turn causes hyperviscosity and predisposed to thrombotic events in a diabetic patients. Hyponatremia, when the serum sodium level is more than 120, and if it is a chronic hyponatremia, mostly they will be asymptomatic. If it is less than 120 and acute, they will show symptoms. When it is less than 120 millimoles per liter, it leads to seizure and coma. Causes include syndrome of inappropriate ADH, TURP syndrome, cerebral salt wasting syndrome, nephrotic syndrome, and organ failures like cardiac failure, hepatic failure, renal failure, and some of the drugs which causes hyponatremia. Other causes are hypernatremia and edema. Hypothermia, which also has multifactorial effects. When the temperature is less than 35 degrees Celsius, patient will have confusion. If it is less than 30 degrees Celsius, then they'll go on to unconsciousness. Less than 24 degrees Celsius, patient will develop apnea. Less than 18 degrees Celsius, there will be absent cerebral activity. And the neurological causes like there will be a period of ischemia and hypoxemia in susceptible patients who has altered cerebral autoregulations like chronic hypertension because of reduced mean arterial pressure and shift of cerebral autoregulation, and positions like sitting position and reverse Trendelenburg position, which lead to intracranial hypertension, thrombotic events, and other causes like intraop seizures and intraoperative air embolism. Evaluation and management. So we have to rapidly assess the patient's airway, breathing, and circulation. We have to maintain 100% oxygen. And if there is any airway problem, we have to re-intubate the patient if necessary. Then we have to assess the GCS of the patient. We have to try waking up the patient and stimulate the patient. Still, if the patient is not arousable, review the history and the pre-op investigations and the drugs used and the timing of the drug used, and if any other drugs which interacts with the anesthetic drugs, and look for any residual neuromuscular blockade. Use nerve stimulator if available. Check for pupils. If there is pinpoint pupil, suspect opioid overdose. Then consider giving the antidotes like naloxone, flumazenil, neosporin, and glycopyrrolate in case of any residual drugs in the plasma. Then measure the temperature. Warm the patient if it is less than 35 degrees Celsius. Check the blood glucose level. If it is low or high, correct accordingly. Then we have to do acid-base gas analysis and look for any hypoxia, hypercarbia, acidosis, any electrolyte abnormality, and we have to correct it accordingly. If no other cause can be found, then we have to suspect neurological sequelae. A complete neurological examination should be performed, and consider further diagnostics like CT or MRI head and neck, and transfer the patient to an intensive care unit for further management. Thank you, sir.
Okay, good. So this is also a topic which have to be thought of from an overall point of various systems in the answer. So I'll just straight away go presentation.